Dr. Mike Jones. He is a consultant acute physician at Durham, and he trained as a neurologist and helped to develop youth medicine as a specialty. Previously, he was a director of education and vice president of the Royal College of Physicians of Edinburgh, and now he is director of this campus. And he's going to tell us today about fluid management, the correct approach. Dr. Mike, please, has 10%.
Thank you very much, Chairman. I'd like to express my thanks for the invitation to speak at this meeting, and also express my enormous thanks for the generosity of spirit that's been exhibited to us, and the very, very generous hospitality, which I'm sure many of the travelling people from the Royal College of Physicians of Edinburgh are taking advantage of. Those of us who have an interest in photography will be taking a very significant number of slides home with us. I'm just grateful we're into digital photography now rather than film, because it would have cost me an arm and a leg. I particularly like this nice warm yellow ball in the sky. I think it's called the sun. The UK needs to get one of these as soon as possible. Intravenous fluids in adults. I'm not going to try and say the correct approach, because I think there are a number of approaches that can be important. However, at the opening ceremony, there was allusion to the historic contribution of Edinburgh to the medical literature. So I'm going to contribute a little bit to that and bring to your attention a gentleman called William Brooke O'Shaughnessy, who was an Edinburgh graduate, aged 22. Pretty much a smart guy to graduate at age 22, and he was from Limerick, which is in an island. So he'd come across to Scotland, studied medicine, graduated, and had a bright career ahead of him, and then he was sent to investigate a cholera outbreak in Sunderland. For those of you who are aware of Sunderland, it is not the centre of the universe. However, he put his heart and soul into this, and noted that the blood of the patients suffering from cholera had lost a large part of its water content and a great proportion of its neutral saline ingredients, leading to venalization, new, thick and cold blood, and established that the stools contained the missing elements in proportion. As I say, very, very smart young man. His therapeutic conclusions were to restore the blood to its natural specific gravity and to restore its deficient saline matters by the injection of aqueous fluid into the veins. This was theoretical. He didn't actually take this any further. But I'd like to take you through something that has changed dramatically and something that's not changed in the next presentation. This is again from 1832. And it's a description. It's really quite florid language. On the floor lay a girl of slender make and juvenile height, but with the face of a superannuated hag. The colour of her countenance was that of lead, a silver blue, ghastly tint. Her eyes were sunk deep into sockets as though they had been driven an inch behind their natural position. Her mouth was squared, her features flattened, her eyelids black, her fingers shrunk, bent and inky in their hue. In short, sir, that face and form I could never forget were I to live beyond the period of a man's natural age. Lovely, lovely English. It's like reading a very, very primitive novel. Now, I'm not going to go through the rest of that, but you can see that he treated the patients. She started to improve, and when he'd given her 6 pints of the fluid, she expressed in a firm voice that she was free from all uneasiness, actually became jocular, and fancied all she needed was a little sleep. Her extremities were warm, and every feature bore the aspect of comfort and health. This being my first case, I fancied my patient secure, and from my great need of a little repose, left her in charge of the hospital surgeon. That was a report by a physician working in Leith, which is the Edinburgh Port. He was a fellow of the Royal College of Physicians, and this was published in the Lancet. The one thing I would demonstrate is the language. If we try to submit something to the Lancet nowadays, to the Lancet, I'm sure it would not be accepted. However, one thing that has not changed. Before before had not been long gone ere the vomiting and purging recurring soon reduced her to a formal state of disability, and she sunk in 5.5 hours after I had left her. I have no doubt the case would have issued in complete reaction had the remedy which had already produced such effect been repeated. So the physicians of those days were no different. They believed they did much better than the surgeons. Dr. Larter's saline solution, however, was quite different to what we would now be used to. 2 to 3 drachms of muriate of sodium, 2 scruples of the bicarbonate of soda in 6 pints of water, and injected at a temperature of 112 degrees Fahrenheit. That's 44 degrees centigrade. That was approximately 58 millimoles of sodium, 49 millimoles of chloride, and 9 millimoles of bicarbonate. 10 of the first 15 patients he treated, unfortunately, died. But it wasn't advanced. Cholera was universally fatal in those days. But is hydration still a problem? And I've shown you here a slide, again from a news item, hospital patients dying of dehydration. You would have thought that this would be old news, but in actual fact that is just from last year and has resulted in quite a lot of publicity in the UK. What is the size of the problem? There are between 12,000 and 42,000 deaths that could be prevented each year if patients received the best possible care. Around 100,000 cases of the condition known as acute kidney injury, and I know that we will be getting a presentation on acute kidney injury, could be stopped by carrying out simple checks such as ensuring patients have enough to drink. An acute kidney injury costs the NHS between 434 million and 620 million pounds a year, more than it spends on breast, lung and skin cancer combined. It's a big problem. And in truth, we've recently published on acute kidney injury, and we know that there are patients coming into hospital with acute kidney injury, but a third of the patients that we saw and published in Clinical Medicine developed acute kidney injury during their stay in hospital. It's done badly. So the National Institute of Clinical Excellence, which Nikki referred to, has recently published a guideline talking about the 5 R's when it comes to intravenous fluid. Talking about resuscitation, routine maintenance, replacement, redistribution, and reassessment. And of those, reassessment has to be critically important if we're truly going to look after the patients whom we serve. Assessment of volume status. I know we don't do this particularly well. But in truth, we are the only people that do it. We have to hone our skills. We need to look at the patient, look at the pulse of the patient, the blood pressure, the capillary refill, and the jugular venous pressure. We should be looking at the respiratory rate. In those patients who are acutely sick, the respiratory rate is often the first indicator that things are going wrong. The presence of pulmonary or peripheral edema, the presence of postural hypotension. It is also suggested we should look at the passive leg raising test. And I'd be interested by a show of hands, because I can see people who know what the passive leg raising test is. That's pretty much universal, nobody does. So it's an interesting issue of passive leg raising can be very helpful in demonstrating whether somebody is likely to be fluid responsive. It's best undertaken with the patient initially semi-recumbent and then tilting the entire bed through 45 degrees. Some patients find that extremely uncomfortable, and it can alternatively be done by lying the patient flat and passively raising the legs to greater than 45 degrees. Between half a minute and a minute and a half, if the patient is volume depleted, there will be hemodynamic improvement simply by that manoeuvre. A very simple clinical manoeuvre. If, on the other hand, the condition deteriorates, of course, the patient should be sat back upright as soon as possible, because it indicates that the patient may be fluid overloaded. A very simple test, and one that I think is massively underused. Clinical monitoring, the early warning score, taking on board many of the clinical factors that I just alluded to, including the pulse, the blood pressure, the respiratory rate, we now have a national early warning score system that mandates a response if patients score highly. Fluid balance charts in the UK, I have to say, are not done particularly well, which is why I've put accurate fluid balance charts. We need to know what the patient is taking in, and we need to know whether the patient is losing fluid. And one of the ways we can do that is by keeping an accurate idea of their weight. Simple investigations do help. Again, the full blood count for the patient who is dehydrated will show the hemoglobin rising. The urea and creatinine, the ratio between the urea and the creatinine, the urea generally being higher in the dehydrated patient compared to normal, and the creatinine level compared to its normal. Electrolytes, and I will be talking about hyponatremia later on today, and it is amazing how many people do not take proper credence of those three simple parameters. These need to be done daily if the patient is on IV fluids. And we should also be aware of the acid-base balance, including the patient's bicarbonate. If need be, we can assess volume status in a more invasive way. I think it's very clear that urine output can be measured in the medical situation with a catheter. We don't particularly like catheterizing people unless it's very, very important to do so. But it can be important to do so, and that assessment needs to be made. An arterial line to measure accurately the blood pressure. The central venous line can be used to measure the right heart pressures. Pulmonary artery catheters are used far less now, but esophageal Doppler is a good indicator of cardiac output, but unfortunately is rarely used. There are other modalities being used to look at cardiac return, including transectional imaging of the inferior vena cava. These are still in the experimental stage. NICE defined, as I said, the 5 R's. Resuscitation. If patients need IV fluid resuscitation, use crystalloids that contain sodium in the range of 130 to 154 millimoles per litre, with a bolus of 500 mils over less than 15 minutes. Unfortunately, when I asked the trainees in the UK what the crystalloids that are available on the shelf actually contain in terms of their sodium content, it is rare that somebody can tell me. Routine maintenance. If patients need IV fluids for maintenance alone, restrict the initial prescription to 25 to 30 mils per kilo per day of water, approximately 1 millimole per kilo per day of potassium, sodium and chloride, and approximately 50 to 100 grams per day of glucose to limit starvation and ketosis. In other words, it's actually quite simple to do with routine maintenance. I'm not sure how well this algorithm projects, but it is essentially saying, again, what I just said, that it's reassessing the patient once you've given a fluid bolus for resuscitation. Give it over 15 minutes. But at the start of that, the blood pressure and pulse should be measured, and then reassessed using the ABCD approach. Does the patient still need fluid resuscitation? In which case, keep going until over 2 litres have been given. At which point, if there is still a problem, seek expert help. If the patient is not responsive to fluids, then it may well be that they will require inotropic support if that's appropriate for that particular patient. The problem that I see is, again, many people don't know flow rates associated with this sort of cannula. The laboratory measurements of flow rate associated with pink implants would suggest that they should be adequate to give a 500 ml bolus of fluid in 15 minutes. But when most of the implants, again in the UK, seem to be put in the antecubital fossa, and the patients are very keen on bending their arms, it is far more difficult to get the fluid in. And indeed, again, asking trainees, what do they understand by flow rates? Most people can't tell me that a blue is completely inadequate to give a fluid bolus. A green is undoubtedly far better. Once we're really up to the large vent plombs, which are more difficult to insert, but probably be a very good fluid challenge, then we are talking about very large flow rates. So there is an issue in terms of making sure people are aware how to give a fluid challenge. Routine maintenance I've already alluded to, but it is a question of reassessment and monitoring the patient. I should say that IV fluids should only be used when they are needed. The primary way to rehydrate people is to give them enteral fluids when at all possible. We're talking about the acutely sick, those in whom it has been assessed that they would not be able to drink, but if it's possible and people will tolerate an NG tube, that becomes more preferable than using the IV route. So fluid maintenance for a 70-kilo man in one day, we're talking from those calculations between 1,750 and 2.1 litres of water per day, 70 millimoles of sodium, potassium and chloride on 1 litre of 5% dextrose included in that 1.75 to 2.1 litres of water per day. So the traditional use of the 1 500ml bag of saline plus 1 bag of dextrose plus 1 bag of dextrose with potassium to give the potassium component actually fulfills that criteria for routine maintenance in that particular patient. But we have to be aware that there are other problems. Fluid and electrolyte deficits or excesses, we're checking for dehydration, fluid overload, hyperkalemia, hypokalemia, and we have to estimate those deficits and excesses. In many patients, there will be other ongoing losses. And with fluid balance charts, it is frequent that people ignore the vomiting or ignore the diarrhea, which is contributing significantly to their fluid loss. Ongoing blood loss with melena obviously needs to be corrected. Patients who are sweating excessively associated with fever also need to have these things played into their equation. And insensible losses for a patient within the hospital setting, even without these grossly abnormal fluid electrolyte losses, can be between 700 and 1,000 mils per day. Redistribution of fluid results in gross edema and also third space losses associated with septicemia and associated with pancreatitis and other major organ dysfunction. So it is important that we prescribe any intravenous fluid by adding to or subtracting from their routine maintenance, adjusting for all sources of fluid and electrolyte loss. This is where I'm afraid it does become more complicated, but in demonstrating to our juniors exactly where things disappear to, it is a fairly nice diagram that shows where fluids will be lost and what it will contain. The problem remains that too frequently I see fluids being prescribed where there is no indication of any consideration of the patient's fluid balance and their electrolyte results as they stand. And this is the sort of attitude I come across within the trainees, now for which fluid most people will take the easy route of, oh, let's just write up some saline and it'll be somebody else's responsibility tomorrow. It's not an attitude which I think we should tolerate or indeed sponsor. IV fluids, sorry, this is going to come up a bit too slowly, I thought I'd taken away the animation here. There are a number of fluids that can be used, and lactated ringers or Hartmans down the right-hand side are very similar in that they contain sodium and chloride ions at a far more physiological concentration than 1 litre of saline. I have no idea why we ever called 0.9% saline normal saline when you actually look at the constituents and how many millimoles per litre of sodium and chloride there are. And indeed, it is drop sodium, that's okay, but when you look at the chloride concentration, if you give too much chloride, you will promote a hypochloremic acidosis, which always strikes me as very bizarre that we're giving a lot of saline to patients who present with diabetic ketoacidosis and can promote the prolongation of an acidotic state by using too much saline. And I must admit, even with dermatologists in the room, I think the paediatricians have got this better than the adult physicians. There are other recommendations, and before the NICE recommendation, there were a number of publications looking at the surgical patients. And because of the risk of inducing hypochloremic acidosis in routine practice, they suggested that crystalloid resuscitation and replacement should be done by using balanced salt solution, e.g. Ringer's lactate or Hartman's solution, to replace the use of 0.9 saline, except in the cases of hypochloremia, when that's resulted from vomiting or gastric drainage. I, of course, would applaud the use of 0.9% saline in a medical patient who has, for instance, hypocalcemia, where the tubular function has deteriorated and therefore the sodium loss can be significant. There are other solutions which should never be used because they can be dangerous, or certainly used with caution. When used in excess, they produce hyponatremia, and one of these is the 4% 0.18% dextrose saline. 5% dextrose itself, they are an important use of free water, an important source of free water, but we have to balance this in terms of the overall biochemical state of the patient. They certainly should not be used for resuscitation. So how much fluid does the patient need? This is a very simple way of trying to do it, although people frequently don't. Obtain a weight, estimate if required, maintenance fluid requirement approximately 30 ml per kilo for 24 hours. Review the recent use and ease. Too frequently, the prescription is written without referral to the recent use and ease. Looking at the recent events, including fasting, intake, losses, sepsis, operations, fluid overload, and check the fluid balance charts. Calculate how much loss has to be replaced and work out which type of fluid has been lost, using the sort of graph that I've shown previously. But remembering that over-replacement can be as dangerous as under-replacement, with significant work by Dilip Lobo from Leicester in the UK showing that the outcome from fluid over-replacement is associated with increased morbidity and mortality. Adding up all the losses over the previous 24 hours and giving this volume as Hartman's solution, or using 0.9% saline with potassium for upper GI and bile loss or excessive urine salt loss. Otherwise, there should be minimized use of saline. There are other recommendations from this group, and indeed has been produced on other studies. The use of hydroxyethyl starch has to be avoided in severe sepsis. There is a significant increased risk of AKI, and that's exactly the problem we start trying to prevent. And the patients at risk of developing AKI secondary to rhabdomyolysis must receive aggressive fluid resuscitation with an isotonic crystallized solution to correct hypovolemia. The specific composition of this crystalloid will be dependent again on the patient's biochemistry. Now, I've gone through that a bit of a gallop. I haven't considered the nutritional requirements of the patient. I haven't considered all the complications of intravenous therapy, but I have tried to emphasize that it should be used only when it's necessary. The best replacement fluid is the way the patient would normally take it, that's orally. The considerations of IV cannulae I have mentioned in passing, but not gone into that in detail, and indeed the considerations of peripheral versus central cannulation and their utility. But in summary, for fluid replacement, it's enteral first, but if IV fluids, thinking about resuscitation, fluid loss replacement, and then how do we maintain the patient. But the importance frequently in the acutely ill remains vitally important. It can be less frequent if the patient is on a chronic IV fluid replacement, but it still has to be done. Too frequently, I see that patients on IV fluids don't get the daily use needs response, and that remains critical if we're going to make sure that patients get the fluid that they require at the time they require it. Thank you very much for your attention.